Hi there, my name is Phil Miranda. I'm one of the occupational therapists here at St. Peter's Hospital, and I'll be talking to you about occupational and physical therapy and what you can do to prepare yourself for a total joint replacement prior to having the joint replacement. I'd like to take a minute to talk about rehab, and rehab being occupational physical therapies and also some of the things you can do to try to prepare yourself for this surgery that you're about to have. For the best results, for your surgery, we tell a person basically to do several things. One of the things you can do is to prepare yourself by getting yourself stronger, work on your flexibility, and work on your endurance. So what you can do is try to work on strengthening your body. There's some exercises in guidebook section 5 that talk about different exercises you can do. I usually tell a person you can do the exercise where you have a little light pain, but all pain, I usually say all pain, no brain. A little bit of pain is not too bad if it's something that you could tolerate, and it's not too bad. So try not to put yourself through too much pain. We tell people try to strengthen your body, your arms included, because your arms will be holding onto walkers, and they're going to be needed to kind of help push you up when your leg is when you have the surgery on your leg. You'll also need to work on trying to walk a little bit more each day if possible, or 10 to 15 minutes is what we recommend. But if you can't walk 10 to 15 minutes, there's other things you can do, like you can get on an exercise bike maybe, or if you have access to a pool, you can go to a pool and try to get yourself to build up your endurance a little bit before the surgery. You can also, like I said earlier, you can work on those pre-op exercises, and we usually recommend that you try to do those exercises twice a day if possible. The exercise you can perform without too much pain, okay? You can also prepare your home. How you prepare your home, I usually tell a person try to pick out a chair that's firm, that's hard, that's easy to get up from with armrests. The higher the chair is, a lot of times the easier it is to get up from the chair. Some of the low chairs can make it pretty difficult for a person to get up from. Next thing is think about if you have a recliner, great. Recliners are nice because you can elevate your leg, and that's one of the things that we usually recommend is to get some elevation so that there's less swelling. So recliners are fine as long as you don't sink all the way down and you can get up and down from it. Specialty beds, I can't remember the last time I've ever ordered a specialty bed except maybe back when I worked in rehab. So we'll teach you how to get into your own bed, and we have some tricks up our sleeves. We could show you how to use maybe a cane to help lift your leg to bring it into bed, or we'll show you some other techniques so your therapist can work with you on that when you go through your therapy. We tell people look at your home and just kind of pretend that you're going home with a walker. Will you be able to navigate through your home safely? Are there area rugs that might trip you up? If they are going to trip you up, you might want to remove them or secure them so that you can go from point A to point B safely. If you have a lot of clutter, we usually tell a person try to make the paths as clear as possible so you can maneuver with a walker. Most of our patients go home with a walker, so make sure your home is accessible. If you're the cook at home, you may want to cook some meals beforehand and freeze them so that you don't have to subject yourself to somebody else's cooking if you don't like their cooking. So you might want to have those meals prepared beforehand so that you don't have to hassle too much with meal planning once you have the surgery when you go home. And if you have pets, sometimes I had one patient who had a horse, so she needed help with her horse. And some people have dogs the sizes of a horse, so you may want to have somebody assist you with your pet. So try to think ahead with your pets and have somebody help you out as needed. And handrails and grab bars, those types of things. If you have them at home, a stair hand rail that's a little loose, we would tell you try to make sure that any grab bars or handrails are secure. We don't want you going home and then depending on it and then it breaks and you actually fall and get hurt. So we don't want that. Okay? So prepare your home before the surgery. Okay, this next slide that we're going to see has to do with the hospital after you've had the surgery, when you get to your hospital room. Your daily hospital routine will basically consist of getting up for each meal. So we encourage all our patients to be up for all their meals. I generally tell a person if you're going to be up for your meals, it's also not a bad idea to get the person to get dressed, because the hospital gowns that we have here were invented by a guy named Seymour Bottom. So it's a good idea to have clothing that will that you'll be able to wear, because you will be leaving your room, possibly walking the hall, and just so that your modesty is protected. So we tell people, try to bring some loose-fitting, comfortable clothing that you would normally wear at home, so that you could actually practice dressing with the occupational therapist. Let's see. The expectation, like I said, is to be out of bed for all your meals, and therapy times will be posted on a dry erase board that you see on the slide. That dry erase board will also give you some information like who your tech is and who your nurse is. So it's good to know that. Sometimes it will have also your therapist names on the board. We try to get the schedule also posted for the following day. So that's going to be really important for your coach if they want to be present for your therapy sessions. So when you arrive in your room sometime in the afternoon, that dry erase board, they'll probably fill it out sometime in the afternoon, and that information will be posted so that you'll be able to have your coach present for your physical therapy sessions. And if you feel comfortable, you can have them present for your occupational therapy session the next day. That brings us to the slide about occupational therapy. What is occupational therapy? I'm an occupational therapist, and basically you can think about occupational therapy as the functional therapy. We work on everyday, daily activities of living, which would be things like self-care, dressing, bathing, grooming, those types of things. So we'll work with you on everyday things. After a joint replacement, it might be hard to put on your clothing. How do you get your clothing on if you have hip precautions? Or how do you put on clothing if your knee was replaced and it's hard to get down to your feet? Or how do you put on your socks and shoes? So we'll go over things like that. How do you carry things if you're using a walker when you go home? And if you're by yourself, how do you transport things from point A to point B? So we'll go over things like that. How do you get in and out of bed, like I said earlier, if you're having trouble with lifting your leg up after a surgery? We could teach you those types of things. So occupational therapy, we generally try to see a person post-op day, the day after your surgery. And the sessions are usually, it's about one session per day, and it's usually, my sessions last about 45 minutes to an hour. It varies from therapist to therapist, and patient to patient, depending on the patient's needs. And this slide is just talking about what we do, which I kind of already mentioned. We teach you dressing skills, go within precautions if you have precautions. Not everybody has precautions. Complete toilet hygiene task, household mobility, use adaptive equipment. And the adaptive equipment might be temporary, or for some people, they might really need adaptive equipment that they're going to use for a long period of time. So we'll go over how do you put on your shoes using a long shoehorn, or we might go over getting dressed using a reacher. Let me show you some common items that sometimes we recommend to patients. In some cases, we might recommend a reacher, a sock aid for putting on socks, or maybe a long shoehorn, or a raised toilet seat. You see a picture of the raised toilet seat, and you have those armrests. That's a safety frame, so that's easier to get up and down from the toilet, which is a lot of times a very low seat. So that can be a little hard for a lot of people getting up and down. We want to make sure you're safe when you do these things. And leg lifter. We can improvise using a cane, turn it around to help lift your leg. But there is something called a leg lifter, which you can use to lift your leg up and into the bed, or into a car, or into the bathtub. And we'll talk about, when your therapist sees you, they'll talk to you about those types of things. I'm going to be introducing you now to the physical therapist who's going to tell you a little bit about physical therapy after joint replacement. Thank you.
Hi, my name is Janice. I'm a physical therapist assistant here at St. Peter's Hospital. I do work on the joint replacement floor, so welcome. I hope that the information that Phil and I are providing you, as well as the other staff here, is helpful to you, more helpful than scary, because it's not scary. So let me talk about the physical therapy part. You may receive physical therapy on the day of your surgery. So it begins the day of the surgery or the morning after. The first time that you will be seen will be in your room at your bedside. A physical therapist will come in and do an evaluation. They'll ask a lot of questions. We want to know the environment that you're returning home to. So that, as Phil explained, some of the things that we may suggest for you to have, some things we may suggest for you to make your home safer, look at those things that look like tripping hazards now. Be mindful now what is difficult for you, because it may be a little more difficult when you get home. So we ask many questions to hopefully send you home to the safest environment. And also so that we can know, do you have no stairs or do you have 20 stairs? We will do 20 stairs with you, so that you know you can do them. We do encourage your coach to be present, somebody who can hear what we're saying, because we provide a lot of information in a short period of time. Your hospital stay is not that long, and perhaps under the influence of narcotics. So you might be a little drowsy and you might not hear everything that we have to say. It may not all absorb. It's helpful to have somebody else, once you're able to, if you are able to in these times, to have somebody present. It's helpful too. You are not having your coach present will not mean that physical therapy will not work with you. We will work with you. Okay. Once groups start back up, the group sessions are 1 or 2 times a day, and I say 1 or 2 depending on if you have had, let's say, you're the patient that has their PT evaluation on the same day as your surgery. So you have your surgery in the morning, you come up, PT comes in later in the afternoon around dinner time-ish, maybe a little later. We work with you, ask you a ton of questions. The next day you will go into a group session. You may only need 1 group session. We may come in, we may get you, you may walk down the hall, do the stairs, we'll do your exercises. I'll explain in a little bit all of the things that we'll do in that group session. What often happens is, as we're walking back to the room, the patient will often say to me, do I have to come to that second session? I feel like I'm good. I want to go home. If you're safe, you're steady, we've acquired a walker for you if you need, and I'll talk about equipment in a moment. You're good to go. You do not need to have that second session. And really, more often than not, that is the case, where patients have their initial evaluation, they have 1 PT session, and they're good to go. The PT session is held in a centralized room, so we do have a big group room. You are with other patients. It's hard to say how many other patients, especially now, but it's fun. It's encouraging to be with other people who have had like surgery. It's not a competition. Patients are very encouraging to each other. It is led by the physical therapy staff. It says on the slide here, it's approximately 60 minutes, and that's pretty much from the time that we come to your room to get you, to go to the group session, and return to your room. It's not 60 minutes of being in that room and heavily participating in nothing but exercises. Who wants to participate in that much? Okay. Perform your exercise program in a monitored setting and cryotherapy. That means we're going to give you some ice when you're done. Icing and elevating are going to be your friends while you're here and when you're home. You want to reduce the swelling that you have, especially in the knees. Knees become very swollen, very tight. It's difficult to bend your knee, and yet we're encouraging you to bend your knee. So work on elevating your leg and reducing that swelling by elevating and icing. It's going to be important, especially in the summer when there's a propensity for us to be swollen because it's so muggy. You'll want to be icing and elevating. Ambulation, transfers, stair training, and education. Those are some of the things that we will be working with you on and talking to you about. And ambulation is walking, transfers is how are you doing getting in and out of bed? How do you do getting up and down from the toilet, up and down from a chair? Are you able to do those? Do you need help? We want you and your coach to know if you need help, what are the areas that you need help in? And often, like I said, we have people who go, oh yeah, I can help mom's elbow up if she needs to help stand up. I can do that. I'll be there. Okay. Stairs, if you have them, like I said, we will do them with you so that you know you can do them and that you can do them safely. And education. So the goals of physical therapy, many of which I just mentioned, let me just run through them quickly again. The average time to meet your goals is 1 to 2 days. The things that we look for you to be able to do is get in and out of bed and a chair. And as Phil said, there is a thing called a leg lifter. Often, especially with our hip patients, it is difficult, or it can be difficult to get that leg in and out of bed. That often is more difficult than walking, getting that 200-pound leg up in the bed. We have some tricks. We will share them with you on how you can do that. And often, people are going home and they've got a significant other, a spouse, a child, who's going to be staying with them that can do that. So, hey, honey, can you help me is often a good option. Walking using a walker or crutches. Most often, patients are leaving with a walker. If you do not have a walker, we will get one for you. That's one of the questions that the physical therapist will ask you when they first see you on your initial evaluation is, what equipment do you have? What equipment do you use? Some patients have used crutches and prefer to use crutches. If that's you, please let us know. It's not our go-to. Usually our go-to is the walker. But sometimes patients don't want a walker, they've used crutches before, they're more comfortable with that. Please just let us know. We make no commission on what you walk out of here with, other than your safety is our concern. If you do have a walker, patients often ask, can I bring my walker in? You can. If you're more comfortable with your walker, or you want to make sure that, that it's safe. Sometimes the rubber feet on the walkers get a little ground down. If you're not sure that it's safe or it feels unstable, you want to have it checked out, yes, feel free to bring it in. Please label it with your name all over it, okay? So tape with your name all over it. Because we have walkers up on the Total Joint Center unit that are used amongst patients. We don't want yours to go missing amongst the ones that we have there. So please label anything that you bring in with your name on it. Like I said, if you don't have one, but you need one, we'll get one for you. You leave here with it. It gets paid through your insurance. Sometimes. There may be a copay, but that's in another slide how that works, okay? Stairs. Getting in and out of a car. We do not have a car on the 6th floor of the hospital. No, we don't. But we will talk to you about how to get in and out of a car, okay? Especially if you have hip precautions. I'll talk about that in a moment. Perform your exercise program. Exercises are important. They will be important when you leave here, when you leave from having had your joint replaced. You don't want that joint to tighten up. I don't know if you have been one of, we've heard horror stories of, you know, my next door neighbor didn't do her knee exercises and now she's in a wheelchair. You don't want to be that person, okay? So you do want to do your exercises. Many of you will be getting continuing therapy, or some of you, whether that's home PT or outpatient PT. And that's for the purpose of strengthening and keeping that joint moving, so that the scar tissue gives you the best pliability and you can move, okay? You don't get stiff and stuck. We don't want that. And follow your precautions. That pertains to if you've had a hip replacement. You may or may not have hip precautions. If you are not aware yet, if you have hip precautions, you can ask your surgeon, am I going to have hip precautions? If you're still uncertain, even after you've had surgery, because certainly we ask patients, do you know if you have hip precautions? And they say, no, I don't know. We are able to identify, because the doctors tell us to write, and they write it in the chart, if you have hip precautions or if you don't. We will go over those with you, if you have them or not. And it's pretty much surgeon based on how they approach the body to get into you to put your parts in. That's just for your hip. There's no hip precautions for knees. If you have hip precautions, I'll just identify it because it says here on the slide, depending on the type of hip precautions, you may or may not have them. They'll usually need to follow for 6 to 12 weeks and check with your surgeon to identify, and they're showing pictures. If you have hip precautions, those 3 things to avoid doing are 90 degrees flexion, or flexion beyond 90 degrees, which is like an L, so you don't want to make that L any smaller by either lifting your knee above your hip and sitting, or bending forward as this person's doing in the picture. It says adduct, that means cross your legs. Don't cross your legs, and no internal rotation or twisting your leg in. But don't stay up studying this all night. We will go over it nearly ad nauseum. You will have the information that you need. Equipment facts. Nearly all hip and knee patients, it says here, need a front wheel walker. In the picture, there's a walker that has just wheels on the front. You can borrow a walker. That's sometimes where people say, I borrowed my neighbor's, I'm not sure it's the right size. Should I bring it in? Again, like I said, yes, you can. We will check it for you. If you bring it in, please label it with your name. If you don't have one, we will purchase one for you, or we'll order one for you, or you can purchase it yourself, but it's covered by insurance primarily if you have it ordered here. So you don't need to bring your equipment to the hospital. Like I said, we have walkers up on the floor for you to borrow if you need. You don't need to bring them. We'll let you borrow what we've got. Ice, as I said, ice is important. Ice is nice. What you can use, I'm sure, or I would imagine many of you are quite familiar with ice at this point. Ice cubes in a bag, gel pack, the Iceman machine, which is a circulating machine of coldness. From what I understand, it's kind of like a sleeve that goes either on your hip or on your knee. Ice goes in a machine, gets plugged in, and that circulates through a tube through that sleeve that you're wearing, and it pretty much maintains cold for a while. Frozen vegetables, perfect solution. Bag of peas, slap it on your hip, it'll last a while. Or an ice recipe, and the recipe for the ice is underneath that in a gallon bag. It tells you rubbing alcohol and 4 parts water. So it's 1 part rubbing alcohol, 2 parts water. Put it in a Ziploc bag. I suggest, because I did it, I made it because I was curious if it was going to work, put it in 2 Ziploc bags. I put it in one, and I didn't. Apparently I had a leak in it, and it was in my freezer, and it leaked, and it was nasty. Put it in 2, okay? We do suggest when you're putting ice on to please place a barrier, whether it's a towel, a pillowcase or something between you and that ice, just so you don't perhaps freeze or burn your skin. We don't want you to lose sensation in that area by leaving the ice on. Ice can be pretty cold. And elevate. As I said, elevating is important. In the picture, they show a picture of somebody lying down. They've got their knee above their hip. Knees usually 6 to 8 times a day, hips 3 to 4 times a day. It says keep your knees straight. If you look at this picture, the pillow is below the knee. It's at the calf. Please do not, knee patients, place a pillow beneath your knee. Okay, we want your leg out straight. We want your knee straight. We do not want your knee bent in a bent position, sleeping all night long, laying on the couch, Netflix and chill for 3 hours with your knee bent. Okay, I know I probably look really stern right now, but that's a very important part that we really need to emphasize. Is it feels more comfortable often for our knee patients to have their knee bent a little bit. It's something that you will want to avoid because you have the opportunity now to work on getting that leg straight so that you can walk better, you'll have better movement in that, you'll have less hamstring pain, which is behind your knee. You have the opportunity to work on that now. If you don't work on that now, you're going to lose that opportunity and you're going to be bent, walking with your knee bent, which may have been how it was before this. Okay, don't disappoint yourself. Okay, so that's why I say pillow, what we call distal to the knee, below the knee, at the calf, not under the knee joint. Please and thank you. Please keep your knees straight. It says your heel 12 to 14 inches higher than your heart, and that's again just to have it elevated to kind of have like a gutter effect, if you will, from ankle to hip, get the swelling down, and sleep with your legs flat on the bed. Please, no pillows under the knees. Thank you for your time and good luck to you.